Yeah. So today I'm going to talk about kind of a project that I've had in mind and some of the work we've been doing to sort of inform this project. I'm going to advance that slide. These are my conflicts of interest. Nothing really relevant here. So the objectives, I'm just going to briefly just go over again the pathophysiology of obstructive sleep apnea. I think we actually talked about central sleep apnea not too long ago, but just kind of review pathophysiology of obstructive sleep apnea, then kind of discuss the implication of this pathology in the context of comorbid disease and treatment outcomes, and I really consider why it's important in West Virginia. Next slide. So when you think about sleep disordered breathing, that's more of a big general term of a lot of different things that can happen. One thing we see a lot of in West Virginia is obesity hypoventilation syndrome, and it's a really complex problem. And actually, our division chief, Dr. Sharma, has really done some interesting work, even looking at the degree of pulmonary hypertension these patients get, which is a huge problem in these individuals. But when we talk about sort of run-of-the-mill obstructive sleep apnea, where you have your airway closure and respiratory events, we really divide that in based on this kind of an arbitrary number, truthfully, the apnea-hypopnea index, which is essentially the number of obstructive respiratory events you have per hour of sleep, at least based on PSG. So greater than 30, we call severe. Moderate is 15 to 29 events per hour, and then mild is 5 to 14. You can move to the next slide. And really the history of sleep disordered breathing it was fairly well recognized pretty early on. This is Fat Boy Joe from the posthumous papers of the Pickwick Club, who was written by Charles Dickens, and he was always described. He was very obese, always described as napping whenever Mr. Waddle would call for him. But this pathogenic role of the upper airway collapse was initially described in the 60s, and then for a long time, really the only treatment, was a tracheostomy. Positive airway pressure therapy really didn't come into vogue until the 90s, and actually another talk I give, I have some pictures from Dr. Sullivan's group in Australia, who had originally developed CPAP machines. The first one was done in 1980. So next slide. Oh, I did include it. So this was the very first treatment of sleep apnea with a CPAP machine, July 9th, 1980. So I believe, from what I recall, this was like a skyscraper worker in Sydney who had fallen asleep 40 floors up on this beam, and his fellow work crew found him, and he got treated. So next slide. So when you think about the pathogenesis of obstructive sleep apnea, on a real sort of basic level, it's really this relationship between things that promote airway collapse versus things that promote airway patency. So you have your pharyngeal dilator muscles, with the genioglossus being the most important, that really sort of maintains airway patency while you're asleep. Because remember, while you're asleep, particularly when you go into REM sleep, when you go into REM sleep, all your muscles are paralyzed. And even when you're, in other stages of sleep, you really lose a lot of sort of frontal context cortical input to your muscles and, respiratory centers. There's also, longitudinal traction. So when you take a breath, there's this tracheal tug that puts tension along the upper airway and helps maintain airway patency. This is all counterbalanced by things that promote airway collapse. So you have this negative pressure on inspiration and things that, really portend airway collapse is fat deposition. Really, the lateral fat pads of the neck are very, very important, particularly in the Caucasian population and what we see in West Virginia. Other ethnic groups, that tend to have more anatomic variation, like Asian populations. It's really driven more by kind of a small mandible and more retrognathia compared to our Caucasian groups. And this risk is all mediated by genetics, respiratory control in the environment. And we used to think of obstructive sleep apnea really as an anatomic disease, but there's actually a lot of really sort of interesting data coming out as we're working more on sort of clinical and physiologic phenotyping of obstructive sleep apnea that there's more to it than just the anatomy. There's alterations in the respiratory centers. There's different sort of clinical phenotypes, like people who wake up recurrently from this disease process tend to have worse sleep apnea. So there's really a lot more that goes into it than this, but I would say, particularly in West Virginia, a big driver of this is, obesity. Next slide. And this leads to, consequences, particularly in the cardiovascular system. The three sort of main things that drive adverse outcomes is, oxygen desaturation. And it's really this phenomenon of desaturation with reoxygenation, desaturation with reoxygenation. You get a lot of oxygen radicals and oxidative stress. You also have a lot of arousals during the night, which leads to increased sympathetic activation. So your sympathetic nervous system is really ramped up. And then these big things in swings in intrathoracic pressure, which puts a lot of pressure and tension across the myocardium, major blood vessels, as well as the lungs, which all contribute to inflammation and metabolic dysregulation. So, next slide. So this is just a study. This was the Wisconsin sleep cohort. It was like 1,400 public employees who essentially the researchers went and said, do you want to do a sleep study? And they said, sure. And then they got a list, they got the results in the mail. So they didn't necessarily get treated. They said, you can talk with your doctor if you want. And so when they followed these folks up, you can see the patients with severe obstructive sleep apnea tended to have much worse outcomes. And you really started to see kind of an uptick when you got into that moderate sleep apnea range. Not as big, really, and there was not really a statistical difference when you were talking about more mild disease. So a lot of times what we might, if someone has mild sleep apnea, they're relatively asymptomatic, we won't necessarily treat them and just counsel them on, diet, weight loss, other things if they're relatively asymptomatic. I'd say common scenario for that is, our anesthesiologists really screen a lot for obstructive sleep apnea now, and it's a requirement if you're undergoing bariatric surgery. So that's one group that we see a lot that are relatively asymptomatic. So next slide. And then this is just looking at, click on through, I think there's some red. Yeah, just looking at odds ratios for hypertension. One group I should mention is, and when I actually did focus groups with you guys, I think everyone was, all over this, but looking at particularly refractory hypertension being on more than 3 antihypertensive agents, very high rate of obstructive sleep apnea in that patient population. On the right, that's just looking at, coronary heart disease free survival by age giant men. And that came from the Sleep Heart Health Study, which was similar to the, Wisconsin sleep cohort, where they had a bunch of people do sleep studies and then follow them up over time. And then down below, this is incident AFib, again, looking at sort of mild, moderate, severe disease. And as your severity goes up, the risk of, arrhythmia goes up. And actually, there's a fairly high failure rate of if you send a patient for ablation for AFib if they have untreated sleep apnea. So we get a lot of patients from our electrophysiologists to get evaluated for sleep apnea prior to undergoing ablation therapy. Next slide. So at least in the, from the epidemiologic studies, it really suggests the presence of obstructive sleep apnea leads to cardiovascular consequences. And great, we have very, very effective treatment. One thing that we've seen in sort of randomized clinical trials is we haven't really shown that the treatment of obstructive sleep apnea, just for your all's knowledge, has a big impact on the endpoint of cardiovascular outcomes, which is sort of interesting because epidemiologic data is so strong. And I think if you guys come across these studies, things to keep in mind is, which is a universal problem, is the people who were treated sleep apnea were in the treatment arm were really not compliant with their therapy. That was a big problem. And they were relatively asymptomatic. And there's been a lot of interesting data coming out recently that it's really symptoms really play an important, are really predictive actually if you're going to have a cardiovascular event. But the idea has always been that you can't really treat you can't randomize people who are severely symptomatic from their sleep apnea to a sham or non-treatment group. It's really not ethical, particularly, the risk of like motor vehicle accidents, public safety, and things like that. So it's been a big holdup of, some of these studies. Next slide. And this is, one of the ones, again, looked at, again, coronary heart disease outcomes, new onset heart failure. And again, this divided the patients based on their symptoms. So it seems like the really sleepy patients with obstructive sleep apnea actually were more likely to have a new incident cardiovascular event compared to others. So this was just one of the studies demonstrating that. Next slide. There's also been some really interesting work recently in looking at obstructive sleep apnea and COPD. Historically, this overlap syndrome, the thought was they're both very common diseases in the population. And so you do get this subset of people who have both obstructive sleep apnea and COPD, but it's just because they're common. They don't really portend a risk for one or the other. But this is some work done by Atul Malhotra and others, looking at patients who were referred, I believe, to pulmonary rehab. So they had, moderate to severe obstructive sleep apnea. And actually the, risk of having sleep apnea was much higher than sort of the 10% in the COPD patients historically. I think this was like 60-some%. And when you looked at the patients who did, have sleep apnea, it was actually a fairly significant amount of fairly severe disease. So, there's probably a signal there that in patients with more severe COPD, there's probably a higher rate of obstructive sleep apnea. Next slide. And this is work from Jose Marin's group in Spain, where they looked at this overlap, the folks with overlap COPD and obstructive sleep apnea. When you looked at just the COPD group and people actually treated with for their sleep apnea, you can see the outcomes were kind of similar. But when folks were not treated for their obstructive sleep apnea, the outcomes were much worse. And this is exacerbation-free survival. And you can see again, untreated group, did worse than the COPD only group or those who were treated. Next slide. And this, again, just gets into, some of the research that's going on now, looking at, physiologic phenotyping of obstructive sleep apnea. So to an extent, people do have to have a degree of anatomic variation that kind of portends collapse. But there's really a lot of other things that play into someone's obstructive sleep apnea, whether it's ineffective pharyngodilator muscle responsiveness, even unstable ventilatory control like high loop gain. We always think of loop gain in sort of Shane Stokes respirations, but there's a sort of milder sort of type of loop gain that can occur in obstructive sleep apnea and lead to worsening apnea during the night. And then I think I mentioned earlier the respiratory arousal threshold. And historically, we always thought of these recurrent arousals of sleep apnea as actually being protective. But actually, what happens when these people have these micro arousals during the night, they develop a very unstable sort of respiratory pattern. They tend to do worse compared to those who kind of sleep through their respiratory events. So it's another sort of interesting finding. A lot of this work is done by Andy Wellman's group at Harvard, if anyone's interested. Next slide. So why is this important in West Virginia? You can see, I think we're leading the charge as far as obesity goes. This is kind of old data. Our most recent data from the CDC, I think it was essentially 40% of our population met the definition of obesity, which kind of was mind-blowing. And I think we're still number one for that category. Next slide. And then when you look at, COPD, one of the reasons we have this chronic lung echo is because unfortunately we still have high rates of COPD. And I was looking at CDC data, and there's some counties in West Virginia that it looks like almost like 20% of the population has COPD. It's really, really unbelievable. We also have some of the worst cardiovascular outcomes in the country as well. So, sleep apnea can be a very important disease to consider, and might really impact the outcomes of some of these other disease processes, as I'll show you next slide. So this is work that we did we just started screening patients who came to our hospital for obstructive sleep apnea. And these were patients admitted, with heart failure, so very high risk of obstructive sleep apnea. And most of the patients really did not, a lot of the patients had never heard of sleep apnea before. One of the reasons we had ruled patients out for considering treatment as previous PAP exposure, which I wish we wouldn't have done in hindsight, but most of the patients were placed on PAP therapy because on BiPAP when they were in the hospital, not necessarily because of the sleep apnea diagnosis. But of the patients we did screen, we ultimately did try and treat 13 people who went through the algorithm. And really, even when we put people on treatment, at discharge, they did not do well as far as adhering to therapy. So even when we identified patients who were at high risk for sleep apnea, they didn't use therapy. But next slide. It really got us thinking. There was this big, this big group of people who were at high risk for sleep apnea that never seemed like they were considered So we followed this up with a large analysis of our Medicaid database in West Virginia. We used the CDC and BFRSS data to kind of look at what are some of the common diseases in West Virginia and what are the diagnostic rate, what is the prevalence rate base, and compare that to what's the prevalence rate in the Medicaid database. Now, this isn't perfect because, you know, we use billing codes, so there's some inherent problems with that. But as you can see, we actually did a fairly good job with COPD, but I think the data kind of played out that we didn't do a good job at looking at obstructive sleep apnea, heart failure, or even obesity. And I was talking to one of our obesity docs here, and she said, one reason you may have found that, and this just to illustrate the billing code problem, is obesity by itself really doesn't kind of qualify you for medications or anything. So, they may not put that diagnostic code in because it's not useful for a lot of the management. Whether that's true or not, I don't know. Next slide. This is some work actually done by Dr. Sharma looking at patients with heart failure who, this was done while he was in Philadelphia, and again looked at patients who were admitted with heart failure, and they were screened in the hospital. A significant number of them actually had a formal sleep consultation with 75 outpatients going for outpatient polysomnography to sort of diagnose their obstructive sleep apnea. 70 had the diagnosis of obstructive sleep apnea, and then you can see over here the patients who were compliant with therapy. Total number of clinic events meant PCP evaluation, acute value evaluation for like shortness of breath or something related to heart failure, ED visits, hospital admissions. So you can see the patients who actually use their device, the total number of clinical events dramatically decreased in these, heart failure patients. A big argument in a lot of these studies, there's actually another large study completed in Philadelphia by Rich Schwab's group, which really showed a massive improvement in readmission rates when you treated their obstructive sleep apnea and heart failure patients. But a big criticism just to keep in mind is, well, if someone's compliant with their CPAP, then they're probably more compliant with their, beta blocker and aspirin and Lipitor and using their medications. I will say that, based on the data, there probably is a signal there, whether that's true or not. That's also a bigger sort of lift, I think, to use a CPAP machine versus taking your metoprolol twice a day. But that is an argument that comes up. Next slide. This is also work done by Dr. Sharma looking at, it's published in Chest last year, looking at patients with COPD and obstructive sleep apnea. Again, this was newly diagnosed obstructive sleep apnea in patients. So you can see that patients with sleep disordered breathing had almost 3 times the rate of readmission versus those who did not. And then when you looked at, severity, mild, moderate to severe, as their sleep apnea got worse, so did their, risk of readmission. Next slide. So, this got us thinking, how are we going to tackle this problem in West Virginia? I think the last time I checked, we had like 9 sleep specialists in the state. And even, getting to a pulmonologist sometimes can be very challenging. So this was a study from Australia where they looked at the management of obstructive sleep apnea in primary care versus, going to an actual sleep center. Now, these primary care providers did have, specific training in sleep disordered breathing prior to the initiation of this study. And this was all done basically with an ambulatory approach, so using a home-based sleep study, and then the majority of patients got treated with an auto PAP. And really what you can see here is following this training, there was really no difference in outcomes. Next slide. And again, this is another study showing that the difference between, this is the same study looking at primary care versus the sleep center specialist, looking at measures such as CPAP adherence, and then ultimately the Epworth Sleepiness Scale score there on the table 3, really showing kind of similar change between the two groups. Next slide. So the PCPs did great, and actually that was a different study now that I think about it. That second study I showed, I think they actually did have a formal titration versus just using an APAP therapy. But so there is some precedent for this training intervention to for PCPs, and then to look at outcomes and with similar outcomes and compared to a sleep specialist management of obstructive sleep apnea. The big problem that they had that, I think this may not translate as well to our population, as patients with severe obesity were excluded, patients with cardiovascular disease were excluded, then patients with lung disease were excluded. I believe the one study, it was COPD or concern of obesity hypoventilation syndrome. And then the other study, it was SATs below 92% were on supplemental oxygen. Those patients with lung disease were excluded. So as I just showed you, these are highly prevalent in West Virginia. So it's really not been studied in that context. Next slide. So just to reiterate, very obese population, and that's really a big driver of obesity in West Virginia. Next slide. And again, the heart disease and COPD. So the next slide, this is unpublished data. So Dr. Doyle, as part of our, we just completed a, focus group study with some FQHCs in the area. And Dr. Doyle had the excellent idea. This is from that JCSM paper that we published, looking at what's expected in West Virginia, what do we see in the Medicaid database. And then Dr. Doyle had the excellent idea of looking at sort of FQHC specific OSA prevalence. So you can see that as you kind of get into these more rural communities, it does seem like the recognition of sleep apnea kind of falls off. Now this is unpublished data. We're doing our focus group analysis now, but we hope to publish this data as well soon. I'd like to thank Dr. Doyle for telling me to reach out to Adam Baus, because that was a very interesting finding. Next slide. There's the man, the myth, the legend himself, Dr. Doyle, at one of our focus groups. From our early analysis of the focus groups, and I hope everyone please feel free to comment on this, but it seemed like everyone thought that OSA is an important disease to consider, but really are not comfortable with management. It seems like a lot of folks really rely on referral for testing and treatment, and there may be some barriers there. The sense I got was that patients are actually fairly open to the diagnosis, but there's some barriers with them following up, whether it's with testing or the specialist for treatment, whether it's travel, expense related to a device or going, and maybe some patients, whether it's important or not, but One thing I thought I might expect to find is patients just really aren't open to discussing sleep apnea. It didn't seem like, like I said, we're still doing the analysis that was necessarily a barrier. But next slide, please. So one of the things we were, proposing, and something we're submitting to NHLBI hopefully pretty soon, is really to see if we can develop sort of a protocol and intervention to better engage and equip primary care providers to treat obstructive sleep apnea. These are just sort of the aims we were talking about. And, one thing I found, I think doing patient focus groups would be very important to really get the sort of the patient side of things, and, better understand what barriers might be present, and then use sort of the work we've done already with some of the, data we get from the patient focus groups to develop a training intervention to enable, providers in rural communities to better manage obstructive sleep apnea, better identify obstructive sleep apnea. A lot of sleep apnea management has really moved out of the sleep center. Most of it now is you have a portable sleep test that the patient just does at home. And then a lot of patients now can just be treated with an auto titrating CPAP machine. So there's really no need for, formal CPAP titrations or anything like that. And then, hopefully if we're able to successfully develop this, maybe trying to implement this at a, clinic site in Southern West Virginia to see, would this be successful or not. Again, I think the, challenge is going to be the previous work done that in this, it was a very healthy population. Obviously, a lot of people with disease were excluded, which I just think would not be a feasible approach in West Virginia, just because of the high rates of obesity, COPD and heart disease. So, next slide. So just in conclusion, the epidemiologic studies for sure showed the strong association between OSA and increased cardiovascular risk. And, I shared with some of the emerging data that, particularly more moderate to severe COPD, there does seem to be a higher rate of OSA. And our preliminary data suggests OSA is, poorly managed and really under-recognized in West Virginia. And I think if we can address that, we really might be able to, impact the trajectory of some of these other sort of common disease processes. Next slide. So I'd love to hear everyone's thoughts, what they think about the proposal. Is this something that folks would be interested in, providers would be interested in throughout the, at different FQHCs, the importance? Would this be too much of a time investment for folks? A common thing is I hear this is another thing for the primary care doctor to worry about. And I know, actually, visiting some of the clinics now, I know how busy everyone is, and it's crazy. The patients are really lucky to have you guys for this, for their care. And I completely understand, just something else you'd have to worry about. So love to get any feedback from folks on the phone about the project.
Hey, Rob, this is Sunil on this side. Can you hear me?
Yep.
So a great presentation. I think that's something close to my heart, considering the work on health disparities in the last decade or so. I wanted to bring your attention to Adam Benjafield's work recently published in Lancet. We had looked at the prevalence across the world, and we were shocked out of our wits where he had proposed, and this is conservative scale, 1 billion people currently who are having sleep apnea throughout the world. Out of that, 170 million are just in Americas, both North and South. So this is way beyond pandemic, and I think that this is not something a sleep specialist would be able to handle on their own. So I think one thing is correct, is that to fight this battle, we would need the help of our colleagues, especially in the primary care. The devastating consequences which is leading to there is testimony to the fact that we can't waste too much time. And the number one thing which will come between us and making any dent in OSA is the health disparities. So the fire of OSA will continue to burn in the rural areas because of lack of any kind of care. Significant amount of untreated sleep disorder breathing will have a spillover over other chronic conditions. And I think one way is what you are alluding to and suggesting and working hard on is how to engage our colleagues working diligently in the rural areas to say this is way more than diabetes. This is way more than hypertension as an issue. And I think how do we connect with them is one area, but I think I wanted to bring to your attention a most recent paper from JCSM, where they not only looked at primary care just like in Australia, they looked at nurses. And it was a non-inferiority trial, and the nurses did the same as physicians. And we're talking about 6-month adherence, we're talking about outcome and sleepiness scale. So I don't think that the burden entirely has to be on the primary care physicians. I think that with the necessary infrastructure and support, having dedicated nurses who are basically focused on this devastating disease would be a great help. And I think this is another area which we need to do and work on. And the other thing is, as you alluded, was our work on hospital sleep medicine. If you look at rural areas, and I can attest to you, coming from Philadelphia, a very similar story in inner city hospitals, is the fact that sometimes these people, or actually I would say most of the time, their primary care depends on their hospital interaction. Sometimes the first time these people interact with medicine is through a hospital admission. So screening them while they're in the hospital before they again get lost in the community is going to be a very important other aspect of tackling obstructive sleep apnea early on. And I think the third is community education. I think we still are very, very far behind in educating our community on the need for proper sleep and the sleep disorders. And I think Healthy Harrison is a very good example of going out to the community, because there's only so much the primary care providers in rural health can do if the community is not actively involved and engaged on both sides. So I think it's going to be a three-pronged solution to make any dent in this severe disease. Thank you.
Thank you.
Thank you so much. That was an excellent presentation, and really seeing the advancements in treatment and testing at home. And I really liked your different graphs and the man, the myth, the legend, Dan Doyle in the picture. That was nice. Does anybody else have any questions or comments, especially regarding the last bit of Dr. Doyle said lots of questions, but he is waiting. So if anybody wants to ask any questions or make any comments, please go ahead and unmute and do so.
In the clinics you guys work in, do you think there would be interest in this? Yeah.
I'll go ahead and jump in, because I wanted to follow up on that exact question that Dr. Stansbury asked a few minutes ago. And there are two primary care providers in this group right now, myself and Beth Hudspeth. Beth is out of the picture, but I hope she can hear me. So I wanted to be a little aggressive at kind of calling on people to answer that question. Looking at what are the different sites represent. Beth, are you there? How about Raleigh Boone and the environment you're in? Is this feasible? Could you be a pilot site for Dr. Stansbury's project?
I'm sorry to say that I just took on a new position at Camden on Golly, but I'd be happy to help. Yeah.
Well, that's great. That gives you about an hour less driving time a day.
Yes, I'm at Summersville and Ansted. Yes.
So
I am excited. I am excited to be close to home again. Yeah.
But would his project be feasible for you?
Camden on Golly is a FA. I always can remember but the same type of site as rural health. So they may be interested. I'm not sure why nobody from Camden on Golly is on this.
Probably because we've never invited him.
Is that why?
Probably.
Because there's a lot of providers at Camden on Golly that would be interested in this, I would think, for education purposes. But it would be worth looking into for sure.
There's two very different rurals on this call. Joe Adornado, you're way up in the northeast corner of Pennsylvania. What's it look like there? And Dr. Stansbury probably isn't going to offer this to you, but if he did at your rural hospital, is this something you guys would be interested in? You're muted. Yeah.
Yeah. I'm not sure. That would really have to come from the clinic director, but right now we've taken on a bunch of projects and we're pretty high with our COVID rate here.
Okay, I'm gonna, but by the way, I see you're an RN from your credentials, and I hope you heard that it didn't have to be, that primary care includes RNs. Charles, you're in Pocahontas, a rural hospital there. And can you see your primary care physicians or your pulmonologist, you have a pulmonologist, jumping on this idea of Dr. Stansbury? You're muted.
May have stepped
Charles
away.
was on mute, I think. Yeah.
Yeah. Chris, you have a Chris Trotter. Are you still here? I was excited to see Chris Trotter. I think he got away. Okay. Well, I'll stop calling roll. Let's see. Well, actually, it's looking like we have mainly rural hospitals here. We got several rural hospitals. Terry, you want to comment for Preston and maybe for your primary care physicians in the community? People are getting busy. It's almost 9 o'clock.
Yeah. Looks like Charles was having a mic issue, maybe.
Mhm.
Well, if he jumps in, it'd be great. But so in a way, what this tells me is we need to get more primary care. Another goal would be to get more primary care physicians from rural West Virginia showing up for this echo so they can hear what you're talking about. And this is a great vehicle, and maybe we should organize a special echo just to talk about this and make an effort to get people on, because our RT presence is really good, but our primary care presence is weak. And even when our FQA sites have pulmonologists, like at Pocahontas and at Southern West Virginia Health Systems, so far we haven't gotten them engaged. So that's a different kind of, oh, I see Terry did comment. And Charles, let's see, Charles Kinnison, Pocahontas, might be a possibility. Terry Hauser, I totally agree, PCPs need to be involved. I'll send you some notes, Rob and Dr. Sharma, separate, but I really hope if you do this that you'll have at least 2 FQHCs, because it's really amazing what the kind of variation you can see site to site. And a crucial variation to me, and Beth, I'd love to hear you comment on this, is whether the standard scheduling protocol is 30 patients a day or 20. People who are seeing, in my opinion, people who are routinely expected to see 30 patients a day, and I see it, it's all they can do to get the prescriptions written. And anything extra is just, I mean, they're in a survival mode. They have sympathetic overstimulation all day long. Between 15 and 20, it starts to be possible if the provider is efficient and has adequate nursing and ancillary support. So that's a reason to try to do more than just one site, so you can compare different organizational cultures and management philosophies. That definitely enters in. I'll stop there.
Thank you so much. Go ahead, Rob.
I guess another question I had was, we were going to do, the plan was to do sort of 15-minute sessions, instruction sessions that are recorded on like a YouTube channel, just like the Echo, that the providers could review at their leisure. We were thinking, it'd be 8 sessions kind of over a month with a hands-on session as well, where I, would attend. What are the thoughts? Our thought is that, if they could do, a 15-minute session here or there, whether it's, at home or, on a Saturday or something, it wouldn't be a huge lift, but I wanted to get folks' feedback on that too. It would be a total of 8 sessions. They could do any time. Beth, what do you think about that? You're muted.
What would happen in the sessions?
So there are different sessions, like, one's just basics of obstructive sleep apnea, things to consider when, identifying it. I don't know if I have easy access to like the curriculum I considered or I'm working on, but it's really like almost modules, sleep apnea and heart failure, sleep apnea and COPD, autopap therapy, CPAP failure.
Yeah, sounds great.
Learning modules.
I mean, what's your thoughts as far as just the weight loss? As far as
weight loss always helps.
That's the big problem if you can get people active.
Yeah. We always counsel on that. Don't have a lot of don't always have a lot of success. When you counsel people, we even, we have a fairly robust medical obesity clinic as well as, bariatric surgery clinic. But that's, even with those resources, a lot of times we don't have much success in getting people to lose weight. I think Grace Ann said is this time there's a shortage of CPAPs. Yeah, it's getting better. A lot of it's supply chain issues.
In the recalls.
Yeah, Philips has, at this point, they're not going to be able to fix the units. It seems like they've started, slowly sending out replacement units. But that is still an issue. I suspect over the next year, it's going to improve. One of the other companies feels like they're going to be able to ramp things back up by summer. But yeah, it's sort of interesting. We have patients now who will get one in, a couple weeks, and then we have people who've waited like 3 months. So there doesn't seem to be a lot of rhyme or reason to it either, for the newly diagnosed.
Rob, I just want to suggest two models I can think of for the kind of primary care education you're talking about. And unfortunately, I don't see either one of them easily applicable, but we have a requirement of a certain number of hours of chronic pain management and opiate management for licensure in the state. All physicians have to do a certain amount of CME every 2-year cycle, I think it is, in terms of pain management, opiate diversion training. So that's a model of mass education. I think you and Dr. Sharma would agree this is just as much a crisis or even bigger, but doesn't have the excitement that one had for various reasons. The other one is the MAT trainings that have taken place, and those are voluntary, but there has been a very big push. So looking at how it was possible to get many primary care providers, including mid-levels, certified. Are you certified for MAT, Beth? I never got certified. It's Suboxone prescribing is what it is. You're muted. Beth, you're muted.
Beth, you're muted.
Yeah, I did go through the course. I have not prescribed and don't have much interest in prescribing, but I did go through the education for the MAT.
Okay, so they got to her, and they got to others, and so if there was, instead of just the 10-minute YouTube or the YouTubes out there, having a certification program and attaching some prestige to that. And of course, if the clinic administrator could see the opportunity to make money by dispensing, actually running the DME side of the CPAP, she or he might be willing to incentivize a few providers within their health center to get the sleep disorder certification to be able to do this. So that's even another potential NHLBI project.
You actually do get a really nice, at least technical fee from the 1 minute setup of one of these home sleep studies. So that's certainly an important thing to consider.
And a lot of the RTs that we've pulled into the clinics through the APHP project have experience and feel knowledgeable about dealing with CPAP. They worked for DME providers. They're familiar with it. So there is a pool of expertise in some of the FQHCs already, but it's with people who are sometimes kind of marginalized, namely RTs. And I guess I'd add them to the RN, as primary care providers for this. Because if they had a physician who'd back them up, there's a bunch of them and say, oh yeah, I'll be glad to do that. I'm ready to go.
Dr. Doyle, this is Sunil here. So that's a great idea, because if you look at our model for hospital sleep medicine, the heavy lifting of the entire service is done by respiratory therapy. So the respiratory therapist is the one who's actually screening all the people who are admitted to the hospital, and then going in and also given a trial of auto CPAP or CPAP, and then following them by an education on post-discharge. So this is certainly possible, and we have a training system over here. We call that a CETCOM. It was recently published in CHEST. And we could definitely use the CETCOM training and certification for RTs at your place if that would help, and I think that's a great idea.
That's an excellent idea.
Krista, you're still there, K2. You're one of those RTs. What do you think? If you're still on, unmute. Luann, if you can get Krista to speak up, I'd love to hear what she thinks about that.
I think Krista had texted me that she was having trouble hearing some of the audio, but this was actually, she and I were texting back and forth. This is something that we've had on our bulletin board that we explored about 1.5 years ago. And then when COVID went crazy, that was an interest. So it's on our board to say, that's something that we want to go. We had brought different ones in to find out how much the different equipment would cost, what codes could be used. So I think it's something, if we could get somebody to work with us on, or, you know, as a provider, be behind it and see what time frame, how much time it involves, we would be interested in doing going forward.
Great, thanks. A metric of progress would be if we had a training and certification that applied equally to physicians, RNs, RTs, and, you know, a year from now, how many people have we got certified in that?
That's an excellent idea.
It's a small thing, but at least it would be a, you know, a measure of some progress getting out to these rural primary care providers with provider broadly defined.
The one thing, Dr. Doyle, you know, I think that's a great idea for, you know, particularly for like a larger study. I guess one question I have for you is, before we did that, you probably want to make sure it works, right? So if they went through the training, are the folks involved comfortable with dispensing these units? Do people, you know, actually get treated for their sleep apnea before we rolled that out? Would you agree?
Actually, we have a philosophy of ready, fire, aim here. And so I think that having that knowledge and expertise is a precondition for getting them to do anything. So so it's something we should talk about more.
Okay.
I guess I don't necessarily agree that it's almost like you have to prove it works before you try even teaching people to do it. And that seems hard to me.
Mm-hmm.
I mean, we could do a first batch at the SIM Center, Rob, and see how that goes. So, you know, I agree with Dr. Doyle. I think the first batch, if they are trained adequately and they are providing those services, they will fire the community by their work themselves. So I think that would probably attract a lot of attention itself. So we can get them. Dr. Doyle, we have a very advanced SIM Center, and they give certification program, and then we can devise one with the help of SIMS, and they would have a chance to come to Morgantown, spend a day, and we could provide a whole certificate training program for them, if that helps.
Excellent. Thank you so much. And yep, we're at the hour. No worries. Sometimes time does fly. But I just want to let you know, the only announcement I have is January 17th will be our next session with Michael Roby discussing update on COVID vaccine and outpatient treatments. So thank you again for the lively discussion. You guys have a really great rest of your day.
Really appreciate all the feedback, guys. Take care.
Thank you.